And this is a challenge that was originally addressed within EXPAND. And most of you, I'm sure by now you've been exposed to a lot of information about EPSOs supporting emergency care, 2 use cases, now moving to CEF. And in between these 2 situations, there was EXPAND. And EXPAND had 2 objectives. One was to maintain what was produced in EPSOs until it's picked up and it gets deployed. But the second objective was to look beyond patient summaries and e-prescription. What is next? So, and of course, what is next is planned care. And the directive is mostly about planned care. It's about sharing care across borders for citizens, not only while they fell in an emergency situation, but in a planned situation. So it's been a long way, but we have finally crossed a bridge from discussing, starting more than a decade ago, on how can we actually make progress around interoperability of health records. Could we actually do that together in Europe? Can we resolve these challenges together? At that time in 2008, EPSOS was launched. Calliope produced interoperability roadmap, and over the years we started to understand similar ways of addressing interoperability challenges, creating eHealth strategies that are quite similar across member states. And then, in 2014, the cross-border directive came in. It provided legal clarity about the rights of patients to cross-border care, and of course, that was a great enabler for doing things. Another important thing about the directive is that introduced the notion of European reference networks that are networks of hospital departments, clinical centers that are very highly specialized to treat particular diseases. And furthermore, particularly rare diseases for which we have little knowledge, there is very few patients, there is very few drugs, and this is a very peculiar kind of network. But for us, it is very important because it provides the ground to study how can we go from emergency care to planned care. Therefore, the bridge we cross is the bridge from mainstreaming eHealth, just trying to say eHealth is important, to actually deploying eHealth and cross-border eHealth. So what 16 member states will be putting in place starting January next year, based on what we've learned so far, it's an infrastructure that contains a generic part, so the member states linking to a central level, and also some core services that are developed at a European level. This is an older slide, but today we know that we do have 16 member states out of the 28, which is a big number of member states committing to this. And what will these member states be implementing? Well, they're going to be implementing the EPSOS pilot services. And there were 2 services, the e-prescription service and the patient summary service. This is a diagram of the e-prescription service that basically says that when a patient is abroad, he has a medicine described at home. He can go to the pharmacist, present himself, his identification in the way Adonis explained earlier, and then the pharmacist should be able to retrieve the e-prescription in the other country, dispense it, and return information back. And we do this through national contact points that are not just technological gateways, they bear a lot of the governance and the responsibility, and they create a lot of the trust. And in essence, we learned that once you produce such infrastructure and you put it in place, we all know very well, you need to maintain it. So a major challenge is to maintain it. Another challenge is to expand it, to make it address more requirements and so on. And in essence, we have maintained and we have improved, learning from a cross-sectoral environment what we can do better for eHealth. But in EXPAND, we also looked at new use cases. We looked at ERNs and how can we apply what we've learned to ERNs. Therefore, just a few words about European network, European reference networks. They're highly specialized healthcare networks. They meet the needs of rare, complex disease and conditions. It is not the patient that travels in this case, it's the expertise that travels, unless the patient has to travel to get, for example, access to specialized equipment. There are multidisciplinary clinical communities, and there's a culture of learning because rare diseases are so rare. The important thing is that registries, clinical registries, are very much linked to care. Therefore, what the outcome of data that is collected during an encounter must go in a registry in a way that can be used by other communities to build up the knowledge around the disease. And of course, in the end, it is about benefits to patients. And this is a blueprint what an ERN would look like. I should tell you that there was a call for proposals, and there should be a few ERNs being set up again at the beginning of the year. Although we have 8,000 rare diseases, they are grouped in something like 13 groups, so there will not be 8,000 ERNs in any case. These ERNs will be very well managed. They are an entity in their own. We know exactly who the members are, and they will produce their own guidelines, and they will have their own tools for exchanging data. And part of this tooling should secure integration of healthcare and research. Although Matt Johnson, who I borrowed the slide from, is a firm believer that they will need information technologies and IT platforms, this is not very evident in the work so far, which focuses primarily on the clinical governance. But this is our opportunity. ERNs are solving what has been very challenging for our community in EPSOS. All the clinical governance, what data do we need to exchange, things that took us a long time to arrive at. So they do have assets, they do have agreements of what data needs to be captured, in what format, and what should be exchanged, but this is not formalized in a way that is suitable for cross-border exchange. So there's a little mention in the implementing acts for the need, for example, to have eHealth tools, semantically compatible exchange of data, shared databases and registries, which gives us a hint that we can actually go and engage there. And what we did in Expand, we set up a task force between the Rare Disease Joint Action and Expand. So we have a small group of experts from the eHealth community and the rare disease, and we're looking at these problems together and ways to actually transfer our experience towards shared care. One of the things we've achieved is to define what are the main priorities for eHealth networks. And I'm starting from priority 2 because it's a typical area where we can have major impact by minimum intervention. So if we could only add to the patient summary as we know it today, the ORFA code, which is a code that identifies the rare disease, then we would automatically address the needs of a large number of patients when they are in a situation of emergency care. Of course, a doctor knowing that this patient has this disease when this patient is in a critical condition is not enough. Therefore, we need additional services so the doctor knows that this patient is in this condition because he suffers of this disease. But because it's rare, the doctor would not know what to do. So he needs two things, either to know where to refer the patient or to know what to do with the patient, or both. And most likely in an emergency situation, he would need to know if the patient comes in this condition, you need to inject this medicine within the first 30 minutes, for example. So we need additional services to produce value for these patients. But this is something that can be done. And the good news is that this extension is already included as a proposal for the next amendment of the guidelines on the patient summary, and we hope that it will be accepted. Priority number 3 relates to the EID question. In the rare disease situation, we don't just simply need to identify the patient and the doctor, but we also need tools to de-identify the data so that it can go in registries and be reused. So that is a challenge in addition to what Adonis presented, which it will probably be the second easiest to address, and the more complex challenge is actually to enable clinicians to share documents of all sorts when they share care together, and to go from these documents to export data into registries. Now I know I have very little time left, so I need to go very quickly to how this might be done. So, as I already said, the first step is whatever new use case you have, we do need to propose amendments to the existing guidelines, because these guidelines, as in the case of Greece, through a national law, we have made a provision that our national patient summary should include, as a minimum, the core data set from the European patient summary. Therefore, the new amendments would automatically mean that our competence center would need to amend. This is already a major achievement. Secondly, we need to go to the European legal framework and to see if this new addition, for example, of the ORFA code introduces new legal problems, organizational policy issues, what additional semantic issues, and so on. So we do have the process here. From emergency care, it is the same. It's a matter of actually repeating this for a new use case. We need eHealth assets, and eHealth assets are interoperability specifications. Now, rare disease people would need very much the same things. We would need to exchange clinical documents, they would need to dispense, and so on. And they do have, as I said, many of them, they already have their clinical agreements on what data needs to be exchanged, but they would still need to create master value catalogs, so create these data models in a way that they can be used for the purpose of exchange, maybe interoperability agreements or data sharing agreements, and so on. So, could we, this is the proposal we've made, given that some ERNs will come into life in January, could we select one or two ERNs? Could we sit with them and understand their needs? Could we help them agree, if they have not done this already, take their agreements on data needs, or help them create their interoperability assets, and understand their own, of course, privacy and legal constraints, and then put the development cycle on the same thing as we've done in EPSA, so understand the policies, open development process of specifications, testing and piloting, then go back to the member states and say, this is the extension of the guidelines, these are the assets that you need to do this, please implement them in your own systems, because once these are implemented in national systems, then the systems are likely to produce the data that then can be exchanged across in a meaningful way. So we need to make provisions of maintenance, but that's another story and another project. It's Value Health looking at this for the future, and then we could have proof of concept. So it seems that it took us, my very last message, George, it took us over 10 years to cross a bridge, but we're now in a very good position to actually leapfrog on the coming use cases. And we still need to find a way to manage this in terms of the European governance and the way that the CEF is working and will work in the future. I think that's all. Yes, thank you very much.
Thank you.